Oh, okay. We're officially open for our annual public hearing. Anyone that wishes to address the board, please give your full name, your full address, and please limit your comments to 3 minutes, please. No one? Okay. Well, then we'll entertain a motion to close the annual public hearing.
So moved.
All those in favor of closing the public hearing indicate by saying aye. Aye. Those opposed? That motion carries. We're officially closed. So we'll start our regular monthly meeting off. And we'll ask for a roll call. Because I think we just barely made it, didn't we, Patricia?
Mr. Brown,
At present.
Mr. Dannenberg,
Here.
Mr. Goldberg,
Here.
Mr. Holtmore,
Present.
Ms. Larson, Mr. Carnan, Mr. Serrano,
Here.
Ms. Vanderblog, Mr. Zylstra, Mr. Benson.
Here virtually.
Yep, Doug is on.
Oh, there you are, Doug.
And Mr. Benson.
Yeah, I'm here. Thank you. An invocation by Mr. Dannenberg, please.
Thank you, Chairman. Dear Lord, we come to you on this beautiful June afternoon with the fluffy clouds and the blue skies. Dear Lord, we also thank for that. We also thinking of the farmers who crops need rain extremely bad. So dear Lord, if it be your will to please pass on some rain to us. We also come to you on this afternoon as a mental health board of Ottawa County. Dear Lord, help us to make decisions, clear decisions, and beneficial to all the citizens of Ottawa County. Thank you so very much. Amen.
Amen. Please note our Ottawa County Community Mental Health Mission and Vision Statements. And for our regular monthly meeting, this is the first opportunity for public comment. So if there's someone that would like to speak to the board, 3 minutes, your full name and full address, please. No one at this point? There'll be another opportunity at the end of our meeting for public comment. So we'll move on to our consent items, which include our agenda for today, June the 27th, as well as the minutes from May the 23rd. So we'll ask for a motion for approval of the consent items.
So moved. Support.
Is there any further discussion? Seeing none, all those in favor of approval of the consent items, agenda and minutes indicate by saying aye.
Aye.
Those opposed, that motion carries. Next is a presentation that Rich is going to deliver for us.
All right, good afternoon. I'm going to be presenting the annual needs assessment. We do this every year, and we really look at our data in terms of persons served and who calls. And so I'm going to present you with that data and then some of our findings. So the very first order of business is when we get this request from MDHHS to do, we are supposed to fulfill their templates and their reporting requirement when we do this. So the calls that we get in, we record, and that came in at a total of 3,245. Sure, slides moving. Let the data catch up here.
There it is.
All right. Okay, you want to move on 2 slides up? Right there. So this is the table of data that shows the total number of people who either telephoned or walked in. So that total comes to 3245. And then in blue is 467. This is the number referred out due to non-mental health needs. 1704, next row, is the total number who requested services from CMH. Of those who requested services, the next line, 683, did not meet eligibility through phone or other screen. Of those who requested services, 1015 were scheduled for an assessment. And then all other calls from the 3245 were either incomplete calls, crisis or emergency consultation, or information only types of requests.
Rich?
Yeah.
Can I ask a question?
Sure.
Okay, that 683, and I can't answer, maybe somebody else can. Didn't meet eligibility. Any examples on that? What's the eligibility? What wouldn't they do it, or what would they do to get that?
It could be a variety of reasons. It could be that they have private insurance.
Okay.
Could be that they they're asking for some behavioral mental health treatment, but they're really more at a mild level. So we might refer those people to a community partner who provides that service for people.
Yep.
Or back to their Medicaid health plan, because the Medicaid health plans cover the mild to moderate benefit
Okay.
in our system.
So too much money? Or you should say that they're too well off. Would that eliminate them, or?
Well, if they had private insurance through a job,
Yeah.
that might be a reason. We do assess ability to pay,
Okay.
but we really look at each individual case and see if they meet our criteria.
Okay. If they can pay, do we do it that way, or do we not want to?
Yep, we do. Mhm.
Okay. So if
We-
somebody's got the money, they can pay, right?
Yep, we assess their ability to pay, and
Okay.
if they can pay,
Okay,
we would expect them to do part of that.
okay. Thank you, Rich.
So really, it's just Medicaid is the last payer of resort, so we always have to
Okay.
make sure that in the end, Medicaid. Okay.
I had a question also, Rich.
Yep,
The 3245. So if you take out the 467 that referred out,
yep,
it leaves you 2788.
yep.
And then the 1704 are receiving services.
So the 1704 is, those are the ones that requested CMH services. Yep.
What happened to the other 1084?
So you at the bottom is the other,
Okay,
you see that, the 1074.
Yeah.
So it's right around there. It's those people that either completed the call. We still write it down if they call in
I
to
see.
track the numbers. So they could be referred to crisis as well, or emergency services, which is not like,
But they did
it's more
not-
emergent. Yeah.
They did not request services.
The crisis or emergency could be, but then we refer them right away. We
Okay.
address that issue.
Okay.
Okay. All right, so of those that were scheduled for assessment, how many did not receive eligibility determination, dropped out or no show? There's still 213 of those. So what's happening is the numbers get lower and lower. Of those scheduled for assessment, how many did meet eligibility criteria? That was 100 and did not meet eligibility. So that's another minus 123. Of those scheduled for assessment, how many people met CMHOC eligibility criteria? That was 679. And I'll show a graph of this and how it plays out. And of those meeting eligibility immediate for admission criteria was 678, because we had one that we had to get into emergency right away. So next slide. So this is how it played out. We had 3245 that came in. And then the actual number that requested CMH services was 1704. People who were scheduled for assessment was 1015. And then people who met the criteria was actually 679. So which is in line with other CMHs. We're usually down to that number. It's about a 21% that we end up letting through for services.
That stayed pretty consistent.
It does, and you'll see the trends here. So next two. So here's the trend over time. 13, 14, 8, 27, and we're now FY 2021. So that's the data we're looking at, was actually last year's data. And total number of individuals assessed is what we're showing here at 1015. So, it's climbing a little bit in terms of, year after year. That's also, keep in mind, that was also right around last year of FY 20, when we were right on COVID too. So
This is annual. Do you do it monthly too?
no, this is annual. So we gathered the data right around March, February, March. This year was actually, they gave us a month extension. It's usually due February, end of February. So for this data set was March.
So this is what we get our per member per month from?
No,
No.
that's different. So per member per month, we get from a total number of Medicaid lives enrolled and unenrolled. And then the calculation that way. This is just who comes to our door or who calls in. So here's another breakdown of that data as well. So in terms of the different populations that we serve, so we have adults with IDD, which is shown in the green at about 113. Adults with MI is the red, and in the middle, children with SED, showing the greatest increase from the last time that we ran this number. So we went from 332 to 435.
Okay, the abbreviations, Rich.
Yeah,
The IDD. and-
intellectually, developmentally disabled.
Okay, and the one with Michigan, MI.
MI, mentally ill,
mental,
adults
okay.
with MI,
And then SFD.
serious emotional disturbance. Yes.
Interesting. I got some more questions, a little bit.
Okay,
If someone calls into the mental health office and more or less says they are struggling with committing suicide, what's usually how does that handle? I mean, you don't let them go, do you?
No, nope, we would hook them up immediately with our crisis services.
Okay, so,
And someone would jump on the call and talk to them about
Okay.
what's going on.
okay, and you won't look at the money situation
No.
or the eligible, nothing?
no,
Our crisis services are available to anybody in this county.
Okay,
Doesn't matter what their
Okay.
insurance or their income.
okay, thank you. I think I'm getting
Okay.
it.
so really this is more for, the total numbers is more for the non-emergent. But we do address those are
Yeah.
priority. Okay, keep going. So in terms of the data set, we also look at some community data set. One of them is the Ottawa County statistics. So we at the time that this was done, we do the population, we do the unemployment rate, also percentage of students that are graduating, because we're anticipating at CMH, how many are going to be entering our services, right? So we're doing an annual needs assessment. We got to evaluate that. We also look at the percents that dropped out in terms of students. So those are some of the numbers that we do keep in mind as well. Go ahead. We also look at consumer health data. So one of the things that we look at is whether our consumers or the population have a PCP identified, physician care. And then we look at other data set like children that were identified with SED as well, severe emotional disturbance at 5,500. And also among those that fell below the poverty line. There was, in this data finding, there was 184 of consumers are homeless. And another data fact is that Ottawa County is second healthiest county in Michigan. I think we held the first place at some point. We're slipping.
We lost it to Livingston.
Yep, Livingston was number one.
Yep.
Okay, keep going. So as part of this annual needs assessment, we also did a survey and we sent it out. And there were 5 things that were identified by the respondents that needed attention in our CMH, in our area. Access to services was one, staff and wages, housing, COVID-19 was still, still up there, and then transportation was the last one. So in terms of the planned actions that we're going to be looking at for each of these, we've also bulleted there. Access to services, try to increase community education efforts. We also have CCBHC expansion, the SAMHSA System Care Grant, free mental health screening and referrals to youth and families, MC3 project, and of course the millage. For staff and wages were things that we're looking at. So stabilization funds, we've already released some funds to providers that are having a hard time. And then the direct care worker wage increase also. And we've also been working with our HR department as well to make sure that we're advertising for positions internally to other medium besides the normal route that we take because it's been harder to hire people. 3, in terms of housing, we want to explore affordable and accessible housing, permanent housing proposal, units to support residential placement, funding from Department of the HUD program, and one-time housing assistance. For number 4, COVID-19, one of the things that the respondents were saying was face-to-face. So one of our goals is obviously during that time was to increase face-to-face, and I'm glad that it's slowly coming back to that it's no longer as much telehealth, but they're actually able to see clinical staff. And the last one, in terms of transportation, we've done some looking into this, so focused on planning efforts and forums for past several years. This has been it's been a recurring theme in terms of the annual needs assessment. This remains a significant barrier. And even in our leadership team, we invited Kaizen Health Medical Transportation, and they did a presentation. It's more of a custom setup in terms of being able to get consumers to services. So we're still looking into that. Also, our community health workers are helping with transportation of consumers as well. And there have been studies like an Evergreen Commons transportation study that have been done that we're able to glean some good information out of. So those are just some of the activities that we're looking to do with the annual needs. So if you guys have any other questions, you can answer them at this point.
You mentioned positions. How many positions do we still have open?
About 150?
No, that's how many we have
Open?
total.
We have
I
total.
think we probably have, I'm gonna say 7 or 8 open
Okay.
positions.
And some are very hard to fill.
Yes.
Rich, in the access to services, did any of the respondents to the survey, any of them elaborate on any issues that they may have had in gaining access to services?
We looked at some of the comments. I can't remember any at the top of my head that were significant, but I can look them up again. See,
Okay. Well,
Nothing-
I'm just, curious if people elaborated in some case. So at least we have an idea of what some
Right.
people may have encountered in terms of
Mhm.
difficulty. Okay.
yeah, we're
And-
looking at those as well. So we will be looking at them more closely.
On the county statistics, they have the number of special ed students that graduated or aged out. Do they track the number of on an annual basis or fiscal year basis of those entering the system?
So unfortunately, that data set comes from the state of Michigan.
Okay.
And so what they do is they say, here's where you find the data, and this is what you put in the report. And so we copy and paste literally onto their templates for reporting.
All right.
And some of them are so out of date the data set.
Yeah.
So,
Okay, thank you.
Sort of interventions you practice with transportation to encourage or assist clients getting to their service locations?
so one is the community health workers, but that's only for, I mean, it's one of the things that we really can't charge off to Medicaid. And it's been very, difficult in that sense, but we're exploring. The Kaizen Health is promising. But then that requires purchasing, specific vehicles.
So for medical appointments, person's Medicaid should cover that transportation. It's not always easy to access. There just aren't that many options, but we certainly encourage people to use public transportation if they don't have their own. Our supports coordinators, our community health workers will help brainstorm with people, trying to figure out how we can help them get to where they need to go. And we have, on occasion, we will actually we'll go pick them up and take them to an appointment, drop them off.
For emergent services, we have contracts with taxi services, so those ones, I mean, sometimes it's far, but we have no other option, so we have to go through that route.
We were at a convention in the area around Saginaw Bay Area, or that area in there. They had their biggest complaints were from their doctors, all the doctors in there. And they told them, he said, why don't you work with us and try to get a service going, that someone would drive a car to their house, bring them to the doctor's office and bring them back home again. And they finally, the doctors were missing so many appointments, they did it.
Yeah.
With it, and they said, it worked wonderful.
Yep.
They couldn't believe it, how many people canceled their appointment because they knew they couldn't get to a visit.
It sounds like Rich
Kaizen,
mentioned that
yep.
Kaizen
Yeah.
transportation service, that they sort of, that's their job, is to find rides for people,
Okay,
either through public transportation, Uber, taxi services. So that's something we're looking into.
good, thank you.
Any other questions for Rich and his report? Well, thank you.
Oh, you got a hand up in the audience.
Oh, yes, ma'am.
May I speak at this moment on the topic?
Well,
One of the, I guess my son is a beneficiary.
we'll have public comment at the end of the meeting.
Okay, I wanted to comment on the transportation. They're not being completely truthful.
Can you save that thought?
That's,
Okay, save that thought and we'll get to that during public comment. Okay, we'll move on to old business, none, new business. Our June service contracts, attachment A. Sorry.
and thanks for that.
Sorry about that, we didn't move.
Oh, no. not your fault.
Can you hear me?
Yes.
Yes.
Okay. So for this month, we have about a handful of new contracts that we're bringing to the board for approval. The first one is Lakeshore Business Solutions LLC. This is a new professional agreement, and it is for Keith Falkowski to provide fiscal advisory and mentoring services as requested. And it started in the beginning of this month and it will go through 2023. We have 2 new single case agreements with our Indiana hospitals, Doctors Behavioral Hospital and Neurobehavioral Hospital, and they're both located in South Bend. We have a new PCCLS, personal care and community living supports provider Lakeshore Care Corporation, and they're located in Holton, Michigan. And that started also in the beginning of June and will run through our boilerplate, which is a 5-year evergreen. I apologize if I don't pronounce this next one correct. Pendagani AFC is also a new personal care and community living supports provider located in Kentwood, Michigan, also starting in the beginning of June. And their financial category is $50,000 to $250,000 annually. The next one is Real Life Living Services, and they're a new community living supports provider located in Ann Arbor, Michigan, which will start in July. And then I'm actually going to bring one more, Patricia, that's not on the list. I'm sorry. It came to me after I gave you my spreadsheet. Success Care LLC, they're a new personal care and community living supports provider located in Grand Rapids, Michigan. And they have an effective date of 6/24 and with an evergreen contract period through 2026 with a financial category between $50,000 and $250,000 annually. Any questions?
Yeah, and Lynn, you have provided this information so many times to me, but I can't get into it. Why are we dealing so many out of county providers? How does, help me again, explain, how does that work?
Well, we get requests frequently for services that we don't have the capacity in county, despite trying desperately to increase that capacity for like specialized residential group home care. So oftentimes we have to look outside of our county when there's no other placement to be found. So that might be in the Grand Rapids area. Hopefully it's,
Okay.
we're always trying to find Ottawa County, if not within our region, but we sometimes have to go all the way to the other side of the state.
Okay, so an example, someone needs a specialty care and only in South Bend, they have an opening and they can provide that care. Is that what we're?
Yep, those first two are psychiatric inpatient, well, the doctor's behavioral hospital and neurobehavior are
Yeah.
psychiatric hospitals.
Okay.
They happen to be located in South Bend.
Okay,
And yes, we always try to place people
closer,
locally,
but
but there is a severe shortage of psychiatric beds. So sometimes we have to go out of state even.
okay. So thank you,
Mhm.
thank you. I'm sorry I have to ask
No.
again, I'm trying to get that.
But they're all Ottawa County residents that are being
Yes.
served.
Yeah.
Yes.
Any other questions, board members? For contracts? Okay. Seeing none, we'll entertain a motion for approval.
Supported.
All those in favor of approving the 2022 service contracts attachment A indicate by saying aye.
Aye.
Those opposed, the motion carries. Okay, next is our financial statements. Attachment B.
So I'd like to introduce Amy Bodfile-Mast. She is
She
our
looks
new
familiar.
CMA.
Yeah.
She might. She's our new finance manager here at CMH. She's been with fiscal though for many years. And we've worked with her through her work in purchasing and.
Karen let her go like
Let her
that?
go.
Oh.
And
I
Amy.
bet there's hard feelings now.
I think this is your second official week, is that right?
Correct.
So
Yeah.
she came back.
Date
Okay.
six.
Nice.
Yeah.
So,
It's always nice to have in-house.
Yeah, yeah,
yes,
great.
we're happy.
So thankfully, the financials are all
you know, it was very straightforward, everything. I don't know if there are any questions, but Keith left a pretty good template to kind of plop in some numbers after, you know, through May. So if there are questions, you may know more as far as the structure is presented than I do at this point, but certainly can dig into any questions or inquiries you might have.
Well, the people before you, Joanne and Keith, they always dealt with the color red. You don't have to do that.
Yeah.
So I think one of the notable things on this report is that the actual is actually greater than budgeted at this point. Up until this month, it's been reversed. And part of that was because we were still getting in full payments from the Lakeshore regional entities. So those have caught up. So we're doing a little bit better than we budgeted for. However, in our system, there's always quite a bit of lag with claims and payments. So there's that gap could close pretty easily towards the end of the year. We think we'll be pretty close to budget this year.
And
1 quarter left, right?
yeah, our budget runs until the end of September?
Yes. Mhm.
Okay, so then the millage, that's the same thing, right? It looks like we got a pretty healthy fund in there.
Yep, and those dollars, I think, have, you know, we were waiting on dollars coming in
Yeah.
previous months too,
It
but
still looks pretty good though.
yep.
Any other questions? Gentlemen? Okay, we'll entertain a motion for approval of the financial statement.
So moved. Or,
All those in favor of approval of the May financial statement, attachment B, indicate by saying aye. Those opposed, that motion carries. And the famous bucket report. Your first stab at this.
Again, a lot of pre-built templates, so, you know, very straightforward, no red, so guess everything's up to date and current through May on this report. I don't know if Rich or Lynn have other insights based on historical or standing within the LRE, yeah.
This is one that the LRE provides to us, and so.
The ISF, the max is 56,190 that the LRE can put away.
Right.
And so right now, it's projected at about 61, right? 61.9, almost 62.
And the hope was that they would be able to use some of that money to pay historic deficits. Not for us, we're fully cost settled, but the other CMHs in our region, and there's still ongoing debate about whether they can do that.
And this is why we wanted to see this bucket list, wasn't it? Kind of, we wanted to see how the other ones are doing over what we're doing, so.
Yeah, I think it's a good representation of how our region is doing, and if any of the partners are struggling or meeting their budget. But this is for information only. If you have questions, certainly let us know. We can find the answers if we don't know them off the top of our heads.
Any further questions on the bucket list, gentlemen?
So,
Your report.
All right. So I'll give you some updates from the department. The biggest issues continue to be staffing, not only clinical staff, but truly direct care workers. We have a meeting scheduled this week with the department, BP HASA, that's our new name, that's Behavior, Behavioral and Physical Health Administrative Services. So we're gonna have to get our mind wrapped around those initials for a while, but we have a meeting with them, a conference call meeting with them. We are hearing what they're going to talk about is they are actually going to be closing down some beds in the state hospitals due to staffing, which is not good. As we mentioned earlier, we have a very difficult time finding beds. State hospital beds are even more scarce. But when we need that level of service, we really need it. So I will update you when I find out what that meeting is actually about, but that's what I'm hearing they're planning on talking about. I don't have a whole lot of information about the Senate or House bills, other than what I sent you guys an email. Senator Shorkey did propose a supplemental along with the budget process that several items were tie-barred to the passage of his bills 597 and 598. The Senate approved this, but that doesn't necessarily mean that this is a done deal. Obviously, we've got months where the bills have to be talked about. We're hearing that there will be revisions to those bills, but I haven't heard anything in the last week.
In reading that bill, this, I think it was Senate Bill 714, it looked like the only thing that was tie-barred was this $15 million allocation from the general fund to Medicaid funding. And that would happen if his other two bills were approved. There's other stuff in the bill, but it's not tie-barred to that. It's just that extra 15 million that he's put out there as a carrot, so to speak.
I'll keep you up to date as I get information about that. The Board Association keeps us pretty well informed. So from the Lakeshore Regional Entity, and Jim is here, if you guys remember, I introduced Jim. He's our Lakeshore Regional Entity rep who's been virtually coming to our meetings, but nice to see you in person. So last month I was here and we adopted the revisions to the Lakeshore Regional Entity bylaws and operating agreement. And other CMHs all approved theirs with the exception of Network 180, who has some questions that they want to answer before they're willing to move forward with signing or consenting to those changes. So meetings are happening. I believe that they're getting the information they need, but I might need to bring back those two items to this committee, to this board, if it looks like they are recommending changes. So I will keep you informed on that as well. Something that we've also talked multiple times about in this particular meeting is something I mentioned earlier, and that's the past liabilities that the Lakeshore Regional Entity incurred in years past when the Medicaid rates were not covering our costs. Several CMHs used their own dollars to pay for services, and that we've been kind of debating back and forth how those costs are going to be repaid to the CMHs. And the plan so far was to use some of the Lakeshore Regional Entities ISF funds, and the department made a very clear statement recently that they did not think they could do that contractually. So they were not supporting that method of reimbursement. So the next step is to go back to the lawsuit that is currently involves several of our partners, and have a judge help us figure out if we can pay dollars using that ISF. So that's pending, and I will let you know what I hear about that. News from CMH. We continue to meet with our contractual providers, kind of taking that pulse of how things are going. They are struggling, trying to find staff as they have in the last couple months. So far, I think they're doing okay, but again, we keep in real close contact with them to make sure things are going all right. We're proposing a change to the way we pay overtime for some of our positions. That went to, I think, policy and planning, and then I think it's going to the Board of Commissioners, if not tomorrow, soon. It was a very complicated process that we used, and we've really tried to streamline it so that people really are just getting straight payments for what they're working. And so that's going to cost us a little bit more money, but we think it will help in our recruiting efforts to let people know that there's a pretty easily understood way that they will be getting paid for overtime. The other thing that we're going to be working on is a staffing pool to try to help us with some of these vacancies that we have on our crisis team, for example, and also mobile crisis. So what we're hoping to create is a pool of outside the county PH workers who might want to pick up on-call shifts or PRN kind of work for us. So that is also something that we're gonna be working on in the next couple of weeks. And that's all I have.
I know that you have one team already out on the street with a crisis intervention team with the sheriff's department. Is
Yep.
there a second team going to be developed?
Yeah, we, through our CCBHC grant, we requested 2 more CIT community intervention team social workers. So that would mean that we have 4 social workers from CMH. What we're planning on doing for right now is kind of sharing the social workers with the law enforcement officers, because our social workers are going to be doing a lot more training. So a lot of their time will be spent training the other law enforcement officers. They'll have less time to go out in the field. So these 2 new social workers will help kind of round out that need.
So potentially you could have 4 teams.
Yeah, we truly hope that we can get more law enforcement to participate as well. They, due to funding, they could not at this point stand up another sheriff deputy, for example.
Okay.
But the plan is to grow that team.
Yeah.
I can't help but think, going back to the days when former Commissioner Joyce Portman sat on this board and how strongly she advocated for trying to improve those conditions between those dealing with mental health issues and law enforcement and the correctional system. She'd be quite happy, I think, with the efforts that are being implemented.
Good.
It's getting a lot of positive feedback from the community. It was highlighted in our last county newsletter, and I think that a lot of folks see the need, especially now, for not only adults but children in the schools. Any further questions for Lynn on her executive report? Okay. General information, comments, meetings attended. Our next board meeting is July the 25th, right? Can you imagine we'll be here yet?
I think so. To be safe, I would plan on being here.
I'm being here. Okay. This is our second opportunity for public comment. Please give your name, your full name and your address, and try to limit your comments to 3 minutes, please.
I will do my best if it's okay.
Turned around. Let me see if we can. knocking it over, so you have actually something you can rest. That's way better.
Thank you. Hi.
Oh, that looks a little bit.
It does. Just go backwards.
Thank
Good
you.
afternoon. My name is Jewel Wickman, and I'm a mother and plenary guardian of an individual who is a CMH beneficiary who suffers from intellectual developmental disability. He has autism. He is 28 years old, but he is mentally functions around a 24-month-old. I'm also a registered nurse and with a lot of experience in diabetes. So I'm coming to the board today because I am asking you for help. I am the only parent here that's probably courageous enough to show up out of fear for retaliation. What you have heard here today is not the full story of what the people are truly bearing at the hands of the CMH management. And we are completely and utterly defenseless, gaslighted, and burned out from the, I guess you could say, exploitation and mental abuse that a lot of parents are complaining about. So if you could just please give me some time, because I am speaking on behalf of several parents here. I encourage you, in fact, I am pleading with the board to please allow a town hall. If you allow a town hall where people can speak openly, parents, Medicaid recipients can speak openly about what they are actually experiencing with the CMH services, then you will hear the entire truth. The IDD population that you service are those with intellectual developmental disorders, such as individuals with autism, cerebral palsy, Down syndrome, fetal alcohol syndrome, just to name a few. We say IDD all the time. The parents are listening to your board meetings, and we hear you say IDD, we hear you say DAB, but what we're talking about is the adult and children, autistic children, cerebral palsy, Down syndrome, fetal alcohol syndrome, children who are chronologically adults, but mentally, developmentally delayed, that they are still 2 to 4 years old. That is the patient population. That is the client base that is bringing in the largest revenue to CMH. And for the right reasons. It's because they're the ones that need the highest level of support. And the federal government understands that. So they understand that. And what is concerning is that the DAB population also stands for disabled, aged, and blind. That is your largest revenue group. And it is concerning that there is millions of dollars of surplus that is being left over when the IDD population is not even being placed in the community. The ones with the most severe needs that need a ratio of anywhere between 5 to 1, they need a greater than 5 to 1 ratio, they're excluded from your CMH day programs. So Commissioner Dannenberg, when you made mention of what's happening to kids when they age out, or maybe it was you, I appreciate that you asked that question, and you asked so many wonderful questions, and the parents had the real life answers for you. What's happening is that the kids are then given community living support services so that the skills that they learn in school, now they can go into the communities and they can execute a lot of the social skills that they learned in school, a lot of the adaptive skills. But what's happening is that the community living support services are being cut, they're being constrained. So transportation, the children that age out, the children that age out at 26 years old, the 26 to 39-year-olds are giving CMH the largest revenue. Why? Because those are the IDD, that's the patient population that is at the greatest risk of death. As a matter of fact, CMH actually put in something for a grant, for the health grant for IDD individuals, stating that the lifespans of people receiving IDD services are statistically significantly shorter. Adults with any type of developmental disability die an average of 23.5 years earlier. And those with an intellectual disability die 12.7 years earlier than those without IDD. Chronic illnesses resulting from obesity are a significant contributor to early mortality, according to the CDC. And again, these are the CMH words. This is what they put in the report to ask for more money for this IDD population that they serve. Chronic illnesses resulting from obesity are a significant contributor to early mortality. According to the CDC, approximately 1 in 6 people with disabilities in the US in 2018 have been diagnosed with disabilities compared to 1 in 14 people without disabilities. So let's just bring this down to real life. How do you explain to my 28-year-old son, who is mentally 2 years old, that he has obesity from a sedentary life because he has not been kept active after school? Because there is nowhere to go and he's mentally 2 to 4 years old and there's no transportation for him to go anywhere and he's not allowed in your day programs. So how do you explain to him when he gets diabetic complications and now he needs to have a limb cut off? I worked on a diabetic unit. This is absolutely real stuff. And this is something that preventative health is part of the IDD services. Someone who is 2 to 4 years old with a developmental disability will only understand waking up after being sedated and not having a limb and not understanding what is going on. So preventative health services are absolutely critical and the funds are there for that reason. Now, what is even more disturbing is that during the pandemic, $2.35 was given to direct care workers, frontline workers, okay? Extra money, additional money was thrown in was either given to the CMHs or the PIHPs and also given into increased capitated rates. So for every Medicaid eligible life, depending on where they live, their age, their sex, and their disability, CMH gets a allotted amount of money. What is happening right now is that the unit rates for people for community living services are being constrained so much that they can afford a worker, but they can't afford benefits for their workers. They can't afford transportation to go anywhere with their workers, and they can't even afford activities. So what happens is that the direct care workers are getting extremely frustrated because they have nowhere to take our children. And the children are starting to act out based on social isolation and they're getting behavioral. And then who benefits from these behaviors? Community mental health does, because now they can bill for behavioral treatment plans at $526 every single time. And this is repeated. Someone with a behavioral treatment plan alone, someone with my son's severity is probably at about $20,000, about $13,000. So is about $13,000 for behavioral treatment planning, and the results, the outcomes are not there. Those children that have been having behavioral treatment plans from community mental health are not getting better because they are socially isolated.
Patricia, do you have her name and full address that we can?
Sir, if I could please finish.
Well, we really need to.
We gave you 3 minutes more than the normal 3 minutes. And then if we set precedent, we're gonna have a problem with that.
I understand, but may I please, I am asking you, please.
How much longer do you need?
1 minute.
Okay.
Thank you.
Okay.
$2.35 was given to direct care workers. Okay, so $2.35 was supposed to be given to direct care workers in the fiscal intermediary contract with the FI and the CMHs. It says that they are to bill Keith Felkowski at CMH for the $235. What's happening is CMH is now taking it out of community living support services. So that is taken out of the budget that should be used for transportation activities for them. They're getting the surplus. There's over $60 million of surplus. Why is there over $60 million of surplus? The surplus is because of the high unit rates that are being allowed to the in-network providers. Supports coordinators are able to bill for $772, anywhere between $440 to $772 an hour. We're talking $193 every 15 minutes, but direct care workers are only $66.50. So the The Medicaid beneficiaries that you serve are truly the most vulnerable, and the money is there because they are the highest risk. But the secondary beneficiary is the CMH. So we are beg you to please ask the right questions. And if you don't know the questions to ask, please ask the people.
Will you be able to get her address so we can respond?
May I put it off the record?
What if-
May I tell you, I don't want to,
No.
this is a tape. Yes.
tell-
Write it on a piece of
yeah,
paper or
write
something.
it on a piece of paper.
That way you can get it, that way you can get an answer. Otherwise, all right? Get your answer. Is there someone else?
Yeah.
Oh, okay.
Can I go or do you need to wait?
No, come on up.
Okay.
We'll do that.
Hello, good afternoon. Good afternoon. My name is Tom Zviers. I'm the regional director for MOCA nonprofit. Business address is 715 Terrace Street in Muskegon, but we are also based in Ottawa County. I supervise the residential services in Ottawa County. I wanted to say thank you to the clinical team for that works with CMH that is helping the people that live in specialized residential homes. I wanted to note that they provide excellent care and support to our team, for which we are very grateful for their help and assistance with clinical matters. So these are people who have nursing issues, who have occupational therapy, who need occupational therapy help, who need behavioral help, and psychiatric help. Without their assistance, without their guidance and their cooperation, the people who need the services the most would be in very bad spot. We are very grateful for that. Also, to the points that were shared earlier before about the shortages in staffing, I wanted to add to that. Currently, we have in our homes at MOCA, we currently have a number of openings, and 2 of them are within 15 minutes of this location. And we can't fill, we have open beds, we are ready to welcome people, but we can't because we don't have enough staff working in those locations. So there's availability for people to come in and receive services, but we just don't have the staff that are available. We are getting referrals from out of counties as well. So just something else for you guys to consider. We are getting referrals for services from out of county. We would very much, we would prefer to work with Ottawa County referrals and support our own folks, our own people who need services here. But we need to fill the beds, so we are taking referrals from elsewhere. We are supporting a number of people from out of county right now. And let's see, the last thing I was going to mention is that in Kent County, you may know this already. There's a couple of agencies that work in Kent County that hire staff that then lend those staff to provider agencies to work in the times of crisis. Real Life, and I can't think the name of one is Real Life. The name of the other one is Spectrum, something the other. I can't remember the full name. But they have helped us in Kent County, our Kent County homes, in times of crisis when we have no staff and we're really in dangerous situations of not being able to sustain operations in a particular home. They were very helpful. That approach, I don't know if you guys can consider that somehow. That's just a bug in your ear. You guys are, we'll figure those things out. But anyways, thank you for your attention. Thank you for your time. I appreciate your work.
Thank you.
Thank you.
Okay, now, public comment online.
Sorry.
Hello?
Hello, we hear you now, Rosalie.
Hi, my name is Rosalie Osman. I live at 457 West 21st, Holland. I really like what the Mocha guy said, and I wish there was more opportunities in county for specialized residential quality care. And the staffing shortage is affecting everyone, especially the self-determination directed services people. We're not getting the support that agencies get, even though we should be considered providers and should be involved in the provider meetings and the provider minutes. Is that something that's posted online? And also, can we have a self-D advisory committee made up of parents that have issues with getting their self-D budgets and authorizations and utilization requests granted? And the LRE board members, will we get, how are they chosen and selected? Who can we like nominate to be on the CMH board? I'd like to have patient portal for CMH to connect with the physical health providers, because the big thing is physical and mental health integration. And in my experience with trying to get an appointment for a med review that was emergent and high acuity, trying to avoid the emergency room, I was told they'll get to you when they have time. That's unacceptable. What is the process for that? Are the providers, prescribers, and medical assistants getting enough time to look at messages, calls, emails? Because going to the ER, they're just going to refer us right back to CMH. And in the meantime, it's going to involve sedation and restraints and traumatization. When the resources are there, can we manage these resources to avoid a crisis situation? And then how will this CCBHC affect the IDD population? Like, the information isn't getting out there that CMH does have a pharmacy. And the triage process really needs work. And where I got a big list. Yeah, in county residential, if there's beds available but no staff, and now there's new providers for staff, when you want to do self-D and have an agency of choice, you're being told you have to use your self-D rate, when an agency should get the rates that they get when they're non-self-D. It's all complicated, but an agency should get agency rates. And even in the self-D technical requirements that was approved, that self-D providers should be getting equitable rates to agencies. And in my situation, I've been providing specialized unlicensed residential for 26 years now. She's aged out of school. We tried 2 different residentials. It was disastrous. I'm still not getting the supports we need for my daughter's best life. 17 years now. There's a service array. I learned out about a service broker in Livingston County. Very progressive people. They have service brokers. I'm trying to get that coordinated here for my family, and it's unnecessary toxic relationship making these requests for your loved one's best life. It should not be so difficult to get medically necessary appropriate services approved and implemented. And it's all about HCBS services. There's so much that CMH is supposed to be providing by contract that it's not. There's so many contract violations. There's no transparency. There's no accountability. You ask questions, you don't get the answers. And then from the health endowment grant, been waiting for my daughter's aquatic center membership from the health endowment grant. Can't get an answer back.
Okay, well, thank you, Rosalie. We have your address and we will get back with you. Anybody else? Anybody else, Patricia?
No.
No,
Okay.
okay. All right. All right, well, if there's no one else for public comment, we'll stand adjourned.
Thank you.